All right, welcome back to our GW JDD Dermatology Translational Science Lecture Series. I'd first like to thank our corporate sponsors and collaborators, Vogt-Koyanagi-Harada and Dermira, however you say it. There's a wrong way to say it. But now on for the main attraction, Dr. John Harris. Dr. Harris is a tenured, and I want to say that heavily because we don't see a lot of tenured dermatologist, tenured associate professor of dermatology at the University of Massachusetts School of Medicine, where he also serves as the director of the Vitiligo Clinical and Research Program. John first came on my radar, I think when I was either a med student or first year derm resident, where I saw this big picture of him holding a novelty check from a small grant he got. And first of all, one, I want a novelty check, but two, I want to know how he grows that beard because I just can't pull it off. But that was small potatoes. Since then, he has received R01 funding, which also not a small feat nowadays. And Scott Noor and I were just talking before that we're lucky to get him in before he wins the Nobel Prize for all his great work. That's not the right picture for him. This is much better. That's the John Harris the world should know. And so that I will turn over to Dr. Harris to talk about vitiligo.
Great, thanks. Thanks, Adam, for inviting me and for the introduction. What he didn't mention was we first met, at a Young Leaders program. Was it in Virginia? Is that where that was? At one point, it was like an SID-sponsored young leadership program, and Adam and I and John Zippin and Mike Rosenblum were hanging out, talking about the future and where we've been and what we want to do. And time goes really fast, and everybody's doing great. So it's great, and I'm honored to kind of come down and speak here at can I call it your program? So I'm going to talk about vitiligo today, and specifically, Adam asked me to talk about my translational research in vitiligo, and I guess that's the seminar is called Translational Research. But there's a lot, since you're clinicians and you're going to see vitiligo patients, I want to start by talking a lot about clinical vitiligo because I think that there's a lot to be learned. And I have people coming up from here all the time to see me for vitiligo. It'd be great for the young trainees. If somebody wants to be a vitiligo expert, we need more of them. So maybe you'll get inspired today and see it as a really fun disease to treat and be the DC contingent. So these are my disclosures. There are a number of them. We do clinical trials. I consult for companies who are thinking about clinical trials. I have equity in a couple. I'm actually a founder of a new company called Valeris Therapeutics. None of these are real conflicts yet because nobody makes any drugs for vitiligo. So we're hoping that these will be real conflicts in the near future. I will be discussing off-label drug uses because almost every treatment that we use for vitiligo is off-label. Does anybody know the one FDA-approved treatment that we have for vitiligo? What's that? It is, actually. So in case you didn't hear that way over there, monobenzone is the only FDA-approved therapy that we have for vitiligo, which is crazy because it makes vitiligo worse, not better. So we need drugs that actually reverse vitiligo. And we'll talk about monobenzone as we go. So vitiligo is really common. It affects about 1 in 100 people. My kids know what I do for a living, and when we go to country fairs and things, anywhere there's a lot of people, they'll say, oh, there's one. And just tell them to put their fingers down. They don't like that, but they're very excited. They're all over the place. I've gone to conferences and been driven around by Uber drivers or somebody, the janitorial staff. I went to a venture capital in Boston, and the guy delivering sandwiches came in with vitiligo. It's a pretty good advertisement how common it is. So that's over 3 million people in the US and many in the world. And half the patients who get vitiligo do so before the age of 20. So that means two things. Number one, as a clinician, I'm optimizing their management over decades of life because vitiligo never completely goes away. We don't have any cures. And as a scientist, it means I get to study the evolution of an organ-specific autoimmune disease over decades. And so I think that it's a fascinating opportunity. And in addition, I say when we study vitiligo, we're studying much more than vitiligo because it has a lot of disease associations like type 1 diabetes and lupus and Hashimoto's thyroiditis, pernicious anemia. In fact, the first patient that really got me interested in vitiligo was admitted to the ICU with diabetic ketoacidosis, new onset type 1 diabetes. And my mentor, who was a diabetes expert, said, why don't you do a physical exam? Full well knowing that I didn't want to become an endocrinologist. And when I looked at her and listened to her heart, it was fine. Sat her up to listen to her lungs. She had a giant patch of vitiligo on her back. And I said, wow, that's fascinating. When did that happen? And she said, oh, everything hit me at the same time, including Hashimoto's thyroiditis and pernicious anemia. So she got 4 autoimmune diseases all at once. And one of them was vitiligo. So I looked at her and said, I want to become a dermatologist. I want to study vitiligo and try to use that opportunity to do translational research because I can get my hands on her skin. I can't get at the pancreas to learn about what causes autoimmunity. So this is how it begins. Tiny little macules of depigmentation, as you can see here. And this is a typical presentation of patchy depigmentation, coalescing of the patches. This is on the hands. The hands or the face are involved in 85% of patients. So hands and face commonly involved, and these are the most visible areas. And so this can be really problematic for patients. It can also become really widespread, as you can see here, head to toe, and patients are psychologically devastated by this often, frequently, not always, but they may not leave their house. We heard about suicides just this morning of patients, people becoming hermits, leaving their jobs. It has a big psychological effect. So vitiligo likes the orifices of the body for some reason. So eyes, nose, mouth, the areola, umbilicus, and the genitals are commonly involved. And interestingly, a lot of times you'll get depigmentation of the epidermis, but not the hair growing within the epidermis. So you can see here you have nice, fully pigmented hairs growing within this, this patch, and that's important. We'll talk about later for prognosis. But you can also get significant poliosis as well, as you can see here. And this is a really important aspect of vitiligo to measure when you're seeing a patient in the clinic, because again, it really weighs on prognosis and response to treatment. This is a halo nevus. These are really common. Patients without vitiligo get halo nevi. I think it's probably a risk factor for developing vitiligo in the future, but lots of people will get these and never go on to get vitiligo. And vitiligo likes to Kebnerize, like a number of other of our inflammatory skin diseases. This is a mountain biker who said part of mountain biking is falling off your bike a lot and banging up your shins, and you can see he recently did that. And so the vitiligo actually lines that area. And unlike what we hear a lot, I think that Kebnerization really only happens when the skin is injured through a cut, and not just from pressure, from wearing a watch, from wearing a belt. This really requires cutting the skin in order for the Kebnerization to happen. This is segmental vitiligo. So segmental vitiligo is a variant of vitiligo that affects about 5% of the population, but in kids it's about 20%. So it's more common in kids, happens earlier. I find this a fascinating pattern. This is one of my favorite types of patients to see because I just love the patterns. You can see here it's limited by the midline, so it only affects one side of the body. Here it's really prominent where you can see it just refuses to cross to the other side of the umbilicus. And there are a number of patterns. She's like one of the cutest patients I have. And you can see really limited to one side of the body, although it does technically cross the midline a little bit on the nose. It's affecting almost the entire nose. This one is also segmental vitiligo, although it looks like it's right in the middle. So if you require that midline limitation, you may not call this segmental vitiligo. But on the forehead, the midline actually seems to shift, and I'm not sure why. But this is actually still segmental vitiligo here. You can see here it can be on other areas of the body. So here is head and neck and chest. It can spread down quite a bit. You can see the same here, again, limited by the midline, affecting one leg. And this used to be called dermatomal vitiligo, which is a complete misnomer. So there's nothing dermatomal about anything I've shown you so far today. This is a great example, right? Crossing multiple dermatomes. This is V3 and a bunch of Cs. This is probably 7 or 8 dermatomes. So it's a problem because dermatomal vitiligo gets people thinking about the nerves. And we actually have no evidence that vitiligo affects the nerves at all. And this isn't dermatomal vitiligo. So we call it segmental. Interestingly, you can get, so the great thing about segmental vitiligo that you can tell your patients, I always say there's good news, bad news, good news about this disease. The good news is you're probably never going to get another spot. It's probably going to stay, what you see is what you get. It begins and ends in 6 months, spreads very rapidly in 6 months, and then stops forever. The bad news is that it actually gets poliosis very early on in disease. So the hair turns white very quickly. And because of that, we don't get much response to typical conventional treatments. The final good news is this is treatable. Segmental vitiligo is treatable with surgical approaches, and that is actually a cure. So when you get a good response to surgery in segmental vitiligo, it never comes back, which is not the case with typical vitiligo. Well, the reason I'm showing you this is this patient actually has mixed vitiligo. This is one of the exceptions to the rule where she has segmental vitiligo clearly on her face, affecting only one side, but then she has vitiligo that's symmetric on her hands, other places. And so this is one of the exceptions when I say you'll most likely never get another spot. If they get mixed vitiligo, they will. And here's another example. Clearly segmental vitiligo here on the back, affecting the right scapula and wrapping around, and also his right triceps area. But he also has it symmetrically on the shins. So this is what we call mixed vitiligo. And Scott, we were talking about this morning, Vogt-Koyanagi-Harada Syndrome. When I show people this syndrome, if you haven't heard about it, it freaks a lot of people out. Because these patients can get very sick. And one of the things that was a clue that this patient wasn't just your conventional vitiligo is that he has such prominent poliosis. So a lot of people can get poliosis, but he really had white hair out of proportion to the amount of vitiligo on his face. And patients with Vogt-Koyanagi-Harada syndrome actually get involvement of their eyes, their inner ears, and their brain. So they start with flu-like symptoms and meningitis from inflammation in the meninges of the brain. There are melanocytes there. The uveitic phase, they actually have difficulty with their vision and uveitis, which is painful. And in the third phase, the convalescent phase, they get vitiligo. They can get alopecia areata and poliosis. And so the good news is usually what people get freaked out about is I've seen, hundreds to thousands of vitiligo patients over my career and never even knew this thing existed. These patients can go blind and need systemic immunosuppressants to prevent that. The good news is they never just start with vitiligo and then go on to get Vogt-Koyanagi-Harada. They actually start in this order with really severe symptoms, severe eye problems, and so they'll often get referred by an ophthalmologist. They'll go see the ophthalmologist first. They have a characteristic appearance on eye exam called a sunset glow fundus. And so if you suspect this, you can send them to the ophthalmologist and they can tell you for sure. But because of the uveitis and the potential for blindness, they need prednisone or another systemic immunosuppressant. So Alezzandrini syndrome, I like to talk about. It's only been reported 7 times in the literature, but it's essentially many of the same symptoms, but it's only unilateral depigmentation and always on the face. And so I think of Alezzandrini as segmental Vogt-Koyanagi-Harada syndrome. And this is a case that we believe had it. She's got segmental vitiligo, as you can see on her face here. She's got a lot of poliosis. And then she had vision changes, ipsilateral vision and hearing changes as well. And so I show this also to kind of try to scare you a little bit into not being complacent with your vitiligo patients. So a lot of times I have vitiligo patients that come to see me. I'm the 5th or 6th dermatologist they come to see. And they say that every other dermatologist told them, there's nothing you can do. There's no cure. Don't worry about it. It's not a big deal. So here's why this can be a real problem. So if you can see here and here, within 3 months, this patient went from very few lesions on the hands to having her hands almost completely covered. 3 months. This patient went to see Khaled Ezzedine in Paris, and he said, I'm going to Africa for a few months to visit my family. I don't want to get treatment until I come back. And you can see within 3 months, he depigmented significantly while he was in Africa. So not always, but vitiligo can be very rapidly progressive. And when that's the case, when it's progressing rapidly, now she's scarred. So I call this a scarring condition because once you get depigmentation on the hands, that's glabrous skin, there's no hair follicles there, that will never repigment. So if you can prevent this, you can actually prevent scarring of your patient's hands and significant body surface area involvement. So if my patients have active vitiligo, I put them on oral immunosuppressants, typically dexamethasone, and I'll tell you about that. So the problem is, how do you know? So if you saw this hand or you saw this, would you know that in 3 months they were going to expand that rapidly and that you could have prevented that? Here are 4 signs you can look for to know that whether your patient has active, rapidly progressing vitiligo. Number 1, trichrome. So typically vitiligo is 2 colors, right? You have depigmented skin, you have normally pigmented skin. That's 2 colors. In trichrome vitiligo, you have depigmented, normally pigmented, and a hypopigmented border around it. So you can see that here, there's 3 colors. That's usually rapidly progressive. Another example is inflammatory vitiligo, which is actually really rare, but you'll see it if you're looking for it. It's almost like the Mona Lisa. You have to kind of look at her outside the corner of your eye in order to see the eyes move. This is the case too. If you look right at inflammatory vitiligo, you really can't see the red. For some reason, I can pick it up with my peripheral vision. But it's a slight erythema just around the border of the lesion. So a lot of times patients with vitiligo will come in and their lesions will be pink. And that's because they've gotten sun exposure, et cetera. So the difference here is that it's not the center of the lesion that's pink, it's only the border. And you'll often get a very light scale around the border and they'll complain that it's really itchy. So inflammatory vitiligo is very rapidly progressing. I had a patient triple his body surface area with vitiligo because he had inflammatory vitiligo. That happened in 3 months. So he went from about 5% to about 15%. So very important to catch. It is not common, but it actually not common for you to recognize and see it because it only lasts for about a month or two. And a patient may only get this once in their entire life. But during that month or two, really rapidly progressive. Confetti vitiligo is another example. Amit Pandya actually just described this just a few years ago. And you can see that instead of having large macules of depigmentation, they're tiny. So there are thousands here of 1 to 2 millimeter macules of depigmentation. Confetti vitiligo is very rapidly spreading, very active. And so these will coalesce in 3 months and she'll have a completely depigmented abdomen if she doesn't get treatment right away. And a lot of times you'll see confetti surrounding a larger patch. So you might have a typical large patch with a bunch of confetti around it. I see it every week. So I have a vitiligo specialty clinic 1 half day a week. And every week I see 5 or 6 new patients and at least 2 of them have confetti. So you'll see this. This is not uncommon. And then the Koebner phenomenon. So when somebody Koebnerizes and you get linear macules of depigmentation like this, that's also a sign that it's active. So stable patients don't Koebnerize. And actually this patient has confetti as well. So you can see the confetti around her Koebnerization. These are 4 signs. If you see any one of them, I would recommend putting your patients on systemic immunosuppression. I like dexamethasone, 4 milligrams Saturday and Sunday for about 3 months. That doesn't repigment the skin, but it holds them in place so they don't worsen while you're getting started on phototherapy or another therapy. Another thing that I like to talk about, because a lot of people don't know about it, is that chemicals can induce vitiligo and actually exacerbate the disease as well. These are some examples. Hair dyes, I'll show you, are one of the most common offenders. And you can see this patient clearly combed hair dye, I can tell you, he combed hair dye into his goatee. A lot of people say, well, how do you know it's really the hair dyes that did it? He combed hair dye only into his goatee and only depigmented where his goatee was. And we actually have some nice studies now. So I collaborated with Abrar Qureshi, the chair at Brown, and to show that in a very large database that where women were enrolled decades ago to determine whether the use of hair dye causes breast cancer. Good news is now that it doesn't. We're able to relook at that data to see if hair dye induces vitiligo. And we can see that if someone one of these nurses used hair dye for more than 5 years or started before the age of 30, the risk of vitiligo was increased by 50%. So that's not really a lot. So remember, the risk in the general population is 1%. So if you increase that by 50%, now the risk is 1.5%. So if you use a lot of hair dye, the risk is 1.5% that you vitiligo. It's still a significant increase and also shows that the use of hair dyes are connected to vitiligo. The hair dye companies actually know this. So if you look in a lot of the boxes, they'll say if you have vitiligo, don't use this product, or you should do a test spot to see if it causes skin lightening. This is what they get sued all the time, and so they know this, and the warnings on the box. A lot of dermatologists have no idea that this is the case, and a lot of patients are really confused by this because they say, I have vitiligo, I've got poliosis, I want to cover it up with hair dye. How come I'm the only person that can't use hair dye? And this is why. So here's another example that I think was fascinating. There was an outbreak of vitiligo in Japan in the summer of 2013. This company, Kanebo, actually developed a skin lightening cream. And in that cream was a new chemical called rhododenol that was fantastic. It actually worked as well or better than hydroquinone. And so they put it into a cream, sold it over the counter, about 500,000 products, and over 18,000 people got vitiligo that summer after using this product. And so the key piece is that the key ingredient, rhododenol, if you look at the chemical structure here, if you remember anything from organic chemistry, this is why we took a whole year of it, I guess, because it comes up every once in a while. Rhododenol looks almost identical to the amino acid tyrosine. tyrosine is a building block of melanin. So melanocytes take in tyrosine, they convert it to melanin, that's where you get your skin pigment. So the melanocytes are fooled by these chemicals that are phenols, and they take up these chemicals, try to convert it into melanin, and they actually get messed up. It's like throwing a wrench in a finely tuned machine. And when the melanocytes take this up, it causes cellular stress. They can't do their job. They generate reactive oxygen species. That induces inflammation that evolves into autoimmunity. So these chemicals can induce vitiligo for the first time, or if you have a patient who has vitiligo that uses these chemicals, it can exacerbate it and you get spread of disease. This is another interesting example. I didn't know at the time, but kids with ADHD can take Ritalin, methylphenidate, a transdermal patch instead of taking it orally. And actually they like it, parents, kids, they like it a lot better because it's a slower onset, slower off. And so you put the patch on one hip and you alternate it every day, hip to hip. And over 50 patients have been described that developed depigmentation or vitiligo at those areas. And a subset of those actually had vitiligo spread to other areas. And this is from the paper. Next to that is the hip of one of my patients who stopped using it, started to repigment actually pretty nicely. And then you can see he's got depigmentation on his neck and in other areas of the body, including genitals, et cetera. So this is essentially vitiligo. So this transdermal patch didn't just lighten the skin in that area, but it induced vitiligo that became widespread. All right, so those are chemicals in vitiligo. So I have vitiligo workup because that's a part of what we do as docs. We work up our patients. I have it in quotation marks because it's not that extravagant. Misha Rosenbach invited me to speak at his complex med-derm symposium at the AAD a couple of years ago. And I said, vitiligo is complex neither in diagnosis or treatment. And he said, that's okay, you can speak anyway. And I was speaking around lupus and dermatomyositis and all these very complicated diseases. Vitiligo is not hard to work up, okay? But it is important to recognize and know what to do next. Usually it's a clinical diagnosis, so you rarely have to biopsy, although I do biopsies every once in a while. Wood's lamp is critical. So having a Wood's lamp, not just for type 1 skin either. Patients who even type 3 or 4, you can see a lot by Wood's lamp that you can't see by room light. I ask a review of systems for coincident autoimmunity. Hashimoto's thyroiditis affects about 20% of vitiligo patients, so that's a high incidence. I do not check a TSH. You can consider doing that. Most people do. I just don't. I like not being a needle doctor, and I see a lot of kids. So I don't check a TSH. We always do a review of systems to try to determine if there's any indication that there might be another autoimmune disease there. Yeah, so that's that. Here's, for the trainees, this is a great example of the use of a Wood's lamp. So this patient has vitiligo, prominent vitiligo on his fingertips that you can't see by room light very well, but when you put it under Wood's light, you can't ignore it. So vitiligo, the Wood's lamp is fantastic in telling us the difference between a depigmented disease and a hypopigmented disease. So almost every disease on the differential diagnosis of vitiligo is hypopigmented. And so if you throw out a Wood's lamp and it fluoresces like this, it's vitiligo. If it doesn't, it's not vitiligo and it's one of your differential diagnoses. That's kind of what I prepared for the residents this afternoon over lunch was the differential diagnosis. What's not vitiligo? It's really kind of neat. So interestingly, this patient came up with his wife. Actually, he wasn't a patient. He flew up with his wife from Peru for an appointment, and his wife had vitiligo. And when I took out the Wood's lamp to take a look at her skin, I went by his chin, and we noticed that he actually had depigmentation on his chin. So we found out he had segmental vitiligo. Had no idea. Probably preferred that we didn't see it. But this is a great example. So even he didn't know that he had depigmentation on his chin, and we found it under Wood's lamp. You just can't ignore it. I wasn't even looking for it. I was going by him to get to his wife with the Wood's lamp, and it just jumped off his chin because it fluoresces so much. Okay, so treatment for vitiligo. The great thing about vitiligo is it's reversible. So this used to be a big white spot. It's almost completely closed now. And you can see that when vitiligo reverses, you get little brown spots within the white spot. So where are those coming from? Hair follicles. Yep, so here's a good example. This means a couple things. So if you have vitiligo, I mentioned this earlier, if you have vitiligo on glabrous skin, it won't get better. And I'll show you an example of that. So pretty much setting expectations. If a patient, a lot of times the resident will be explaining to me when they've seen the patient before I go in, and they say, well, this patient has vitiligo, it's pretty widespread, has been on phototherapy for 12 months and topicals and doing everything right and didn't get any repigmentation. And the first thing that tells me is something's really wrong because everybody responds unless there's something in particular wrong with their vitiligo. So they should, if they're getting phototherapy, within 6 to 12 months, you should see clear benefit. Unless the vitiligo is only affecting glabrous skin. So a lot of times I'll say, wow, why aren't they getting better? And I'll ask, and it'll turn out they only have it on their hands and their feet and their lips. And then that's why. So then now I understand why they didn't respond to phototherapy. Or if the hairs turn white. So I throw this up here because I often say the hair has to be black for the skin to repigment. That's not true. So blondes repigment just as well. But it can't be white. So if you can see this ankle, lower ankle foot of this patient, she's got good normally colored hairs up here that are nicely repigmenting perifollicularly. Down here she's got poliosis and she's got no repigmentation, no perifollicular repigmentation. So the fact that the pigment comes from the hair follicle tells you glabrous skin won't repigment and poliosis won't repigment. So that helps you with the prognosis, setting expectation of your patients. A lot of times they'll come in and they've got it all over their face and all over their hands. And I'll say the great news is that I can reverse your face. Face, 6 months, we won't even know you had vitiligo on your face. The hands, we're never going to make any progress. And so setting that expectation so the patients know what to expect is important. So this is a spot on the foot, glabrous skin, and you can see actually that there is a little bit of repigmentation here. If you look, this is marginal repigmentation. You can see it's feathering in from the sides a little bit. Melanocytes can only crawl a few millimeters at best, so anywhere from 1 to 6 millimeters. And we think that actually reflects the skin phototype. So if you're skin phototype 2, your melanocytes can migrate 2 millimeters. If you're skin phototype 5, they can go 5 millimeters. This was done with punch biopsies previously. So if you put the punch biopsy in and then measure how far out that they would repigment from that. But so she repigmented maybe 2 or 3 millimeters here from the edge. And that's the best she's ever going to get. So it's not 2 or 3 millimeters a year, it's 2 or 3 millimeters ever. So if you have a glabrous skin spot, you'll be able to shrink it. You'll be able to turn it from here to here, and then it's done. This is a patient, just an example of phototherapy. She had vitiligo all over her face, neck, chest, actually all over her body, her legs. And I'm showing within 14 months, she's almost completely repigmented. This changed her life. She said, I can wear low-cut dresses again. This has changed my life. And what I'm not showing you is at 6 months, she completely repigmented her face. She had vitiligo all over her face. And this was the point where I didn't even remember she had vitiligo on her face. So I was looking at her chest and her neck and saying, oh, you're responding well, that's great. And she said, what about my face? And I said, what about your face? She said, I used to have vitiligo all over it. And I said, wow, yeah, I forgot. So I couldn't even find vitiligo on her face afterwards. So remember, face is covered with hair. Whether you're a man or a woman, a kid, doesn't matter. It's vellus hairs, but the vellus hairs are just as good as terminal hairs at repigmenting the skin. This is an interesting example. So this young woman had vitiligo all over her back. And we did phototherapy for about 20 minutes left. Whew. We did phototherapy for about 6 months, and she responded really well, except in a few patches. When you look at those patches, actually, her vellus hairs had turned white. And so that's why she didn't repigment there. And so you can actually use a dermalite to get in and look at the vellus hairs to see to look at prognosis. So I'm going to zip through a little bit. Treatment goals. So people have talked about antioxidants. We know we use topicals. Surgical approaches are good in the subset. I'll show you. UVB is really the best thing we've got because it both suppresses autoimmunity and stimulates melanocyte repigmentation. This is the general response we expect. Steroids alone around 50 or 60% response. UVB does better for widespread vitiligo. It's just as good or better than PUVA, and PUVA causes skin cancer and UVB doesn't. So we don't use PUVA anymore, we just use narrowband. This is my algorithm. It's essentially, are there signs of activity? If so, put them on dexamethasone for 3 months to hold them in place until you can get something else. Do they have more than a couple spots? If not, you can try just topicals. Start them off with topicals. I alternate clobetasol and tacrolimus every week. If they have more than a couple spots or they're active, I get them on narrowband UVB. If they can do it, I get them on it. And then if they're willing to apply topicals as well, we'll combine that. We can always consider excimer laser if there are just a few spots, but generally, particularly if they're active, I like to get their full body treated to prevent new spots. This is my UVB protocol. It's actually really important to do UVB correctly. And you can just download this off our website. Generally, I start at 200 millijoules and go up by 50 millijoules every visit until they get light pink that lasts less than 24 hours. And generally, I like to try to get them to 800 millijoules as fast as I can. Home phototherapy is a thing, so you can actually order a home unit. They list for about $7,000, either from Dablin or National Biological online, but you can actually talk them down to $3,500, I've learned. So like a used car, if your insurance isn't going to pay for it, you can say, and they'll almost always take $3,500. And then this is a one-time purchase. They have it for the rest of their lives. And the response to home phototherapy is just as good as in office. And so I have a lot of people who travel to see me from a long way away, and we just put them on home phototherapy. Surgical treatment is an option. It's kind of difficult to do. It's only done by 3 centers in the US right now, us, Dallas, and Detroit. This is a woman with depigmentation on her back, very stable, which is important. We can dermabrade those areas, and then you actually take a small postage stamp size, very thin graft from the thigh, pull it apart mechanically, digest it in trypsin, pull it apart mechanically, spin it down, resuspend it in a small volume, and then just drip it on the dermabraded areas and bandage that up. And she got a really nice response. It takes about 6 months to a year to repigment. This only works if your vitiligo is ultra stable. So it's fantastic for segmental vitiligo, which by definition is ultra stable. You never get another spot. For non-segmental vitiligo, it's kind of hit or miss. It does not work as well because what looks to be stable non-segmental vitiligo often isn't. So I love it for segmental vitiligo patients. I'm careful with anybody who doesn't have segmental variant. These are some examples. This is the shoulder of a segmental vitiligo patient before and after 6 months. This is the face of a patient on the cheek before and after. This is the abdomen, segmental vitiligo before and after. He had 2 procedures. The chin of a patient before and after, he had 2 procedures. And so because of the lab requirements for this, a lot of centers don't do it, but it's really very satisfying. Patients get really nice results. We talked about monobenzyl ether of hydroquinone. It depigments the skin, so it makes vitiligo worse for the reasons I talked to you before. Monobenzyl ether of hydroquinone is a phenol, looks like tyrosine, messes up the melanocytes. The only FDA-approved drug for vitiligo. But yet, even though it worsens vitiligo, it evens out the skin. And so patients are often very happy after using this treatment because at least they don't have spots anymore. But it's a big psychological step to take. We tell them to treat this as irreversible. And so if you make the decision to turn white, then it's a big decision and you can't go back. And this is what Michael Jackson used. There were empty bottles of this all over his apartment when they went in after he had died of a fentanyl overdose. All right, safety things to think about with the treatments that we use. Topical steroids certainly can cause steroid-induced acne. This is striae from using triamcinolone in a 14-year-old for a very long time. This is not mine, but she came in, and this is, remember, irreversible. I like mometasone for kids, actually. I haven't ever seen striae from mometasone. This is a patient, protopic combined with alcohol can cause flushing. I don't know if anybody knows that, but he had segmental vitiligo, was only using protopic on one side of his face. Said every time I go to a party and have a beer, my face lights up just on that side. And he took this at a party just to show me and prove it to me. But you can tell your patients if they just have like a shot of something at home before they go out and give it 20 minutes, it'll calm down and then it won't come back. So then they can go to the party and drink and they won't happen. So this patient had too much phototherapy. They mistook her for another patient who actually was on a much higher dose. So she got a burn. This happens. Fortunately, it's very rare. This patient came in, we gave him 200 millijoules of phototherapy, and nurse called me and said, he's got a sunburn. Can you see him? So I said, yeah, sure, brought him in. And I said, I've never seen a sunburn to 200 millijoules. That's half an MED for a type 1 skin. And I walked in and he was scratching. And he was like, yeah, it's crazy itchy. And I said, well, that doesn't sound like a sunburn. And he had PMLE. So we just hardened him, and he did fine. So not a sunburn. Things to think about. The risk of melanoma and non-melanoma skin cancer decreased 3-fold in patients with vitiligo. We don't know why about the non-melanoma skin cancer, but this has been shown in 2 very large studies, separate studies. Both showed 3-fold lower risk. And so I think that that's important to know. Patients are always told by their dermatologist that are much higher risk for skin cancer. I think that's intuitively makes sense, but it's just wrong. All right, so I just want to talk about, so we can do pretty well with the conventional therapies, but the question is, can we help more patients? The patients that aren't responding to conventional therapies, can we make it more convenient for them? Can they get a better result? This patient came into my office, as you can see, with widespread vitiligo. He also had received a kidney transplant and was on systemic immunosuppression, and he repigmented faster than anybody I'd ever seen. So this told me if we could put our vitiligo patients on kidney transplant level immunosuppression, their skin would do great. The problem is the rest of them would not. So the question is, can we develop a targeted immunotherapy like we have for psoriasis, right? We target just a single cytokine. We can make psoriasis better. Can we do that for vitiligo too? The problem is psoriasis therapies don't work for vitiligo. And so we knew that we had to find the vitiligo pathway that was equivalent to the psoriasis pathway. To do that, we study a mouse model of vitiligo that have black hair and black skin. And we give them a CD8 T cell that attacks melanocytes and activate those cells. And the mice go on to get white spots on their tail, their ears, their nose, and their feet. And so the first thing we did was we just looked in the skin to see what genes were being turned on in both mouse and human. So here, the human bars are black and the mouse bars are white. And you can see that the genes that are being turned on in the skin are the same in the mouse model and in human lesional skin. And really, so we see a loss of melanocyte transcripts, which is what we'd expect if we're killing melanocytes. But then everything else that's turned on is really interferon gamma and interferon gamma dependent. So we don't see any genes being turned on in the Th2 pathway. We don't see any genes being turned on in the Th17 pathway. This is why psoriasis drugs don't work for vitiligo. This is why I don't think dupilumab will work for vitiligo. When we saw that signature, we went back to the mouse model and we tested to see if vitiligo really depended on interferon gamma. So when we get rid of interferon gamma, or CXCL10, which is an interferon gamma-induced chemokine, the mice were protected from vitiligo. More importantly, we could give the mice vitiligo. So this used to be a black tail, and now it's a white tail. And when we blocked CXCL10 with an antibody at that point, the vitiligo reversed in the mice. And it reversed in the way we'd expect, perifollicular repigmentation. And so this is a model that we've been using, and we're really excited to see this, that not only could we prevent disease by blocking this pathway, but we could actually reverse it. So this is a schematic of the pathway, just to save some time. Starts with interferon gamma, signals through interferon gamma receptor, JAKs1 and 2, STAT1, the chemokines CXCL9 and 10, and their receptor CXCR3. So what happens is interferon gamma turns on these chemokines. The chemokines come from keratinocytes to amplify the response. I'll show a picture of that. And then that recruits more T cells. Kind of like walking around in the summer eating an ice cream cone, you drop a few dots of ice cream. Ants are wandering around. One ant finds one dot of ice cream and then tells all his friends by laying a trail. And then you have a minute later, you have 1,000 ants on that ice cream dot. And that's kind of what's happening here with the chemokines. The first T cell finds the melanocyte, gets angry, makes these chemokines and recruits all its friends, and then vitiligo spreads. And we can block that. So we've now, in the mouse model, we've been able to block interferon gamma, its receptor, STAT1, CXCL9 and 10, and CXCR3 by knocking it out of the mice. They're protected from vitiligo. If we use antibodies against interferon gamma, the chemokines or the receptor, CXCR3, we can block, prevent, and reverse the disease in the mice. And JAK inhibitors prevent and reverse the disease in the mice. Even more importantly, and this is Vincent, who does all of our drug testing in the mice, going to medical school this summer, so we need a replacement in case there's anybody who's looking for a job. More importantly, JAK inhibitors work in people too. So this is a patient who had vitiligo, also alopecia areata. This is with Angela Christiana's group. We kind of worked on this guy together. And when he got oral ruxolitinib, he repigmented within about 5 months. So significant repigmentation on his face in a very short amount of time. And importantly though, when he stopped the drug at week 20, within 12 weeks, the vitiligo all came right back. So this is not a durable treatment. Even though we got a really impressive response, it's not a long-lasting one. So patients need to be on JAK inhibitors for the duration if you want the treatment to be maintained. Importantly, we had his serum saved up from a long time, over a year, and we tested him, and his CXCL10 level, remember that's induced by gamma and recruits all the cells, the CXCL10 level in his blood was very high, highly elevated for a whole year, until he started ruxolitinib, and then it dropped. And so this correlated with his response, telling us not only was ruxolitinib effective for vitiligo, but it was effective in the way that we thought it was, by blocking interferon gamma signaling, dropping the chemokines, and making it better. So also interestingly and importantly, there are now 3 clinical trials to test JAK inhibitors in vitiligo that are ongoing. This is this is Mady in my lab. He's now graduating dermatology residency, but he did this study with me. He's going to join our faculty and study connective tissue diseases. And this is Zenny, my clinical fellow who's running these clinical trials for us. And Aclaris, Insight, and Pfizer are all doing clinical trials for vitiligo. Aclaris and Insight are testing a topical JAK inhibitor for vitiligo, 2 different topicals, and Pfizer is testing 2 different orals. And so now things are really getting going. This is an exciting time. And we're blinded to the treatments, but we're seeing patients get better. So it's pretty exciting. I have a guy who flies in from Montreal every month for one of these trials, and he repigmented his face 100% within about 3 months. Very impressive. So we're hoping he wasn't on placebo, because that would wreck everything. So this is just a summary of kind of what I told you. The T cells get in there, they make chemokine, they make interferon gamma, the keratinocytes make chemokines, recruit more cells. And what I have here in red are existing drugs that have been developed for other diseases that are just sitting on the shelf in pharmaceutical companies that could be pulled off the shelf and tested for vitiligo. They've already been through phase 1 and phase 2 clinical trials. They're safe. They just didn't have any efficacy in the drug, in most of them tested in psoriasis, which is not dependent on this pathway. All right, so the final thing I want to tell you about is a new story that I think is really exciting. I'm really excited about it. I mentioned to you that JAK inhibitors, and I didn't mention, but conventional therapies are not durable treatments. So as soon as you stop them, the disease comes right back. And it comes back in the exact same spots they had before. Thierry Passeron in Nice, France, actually did a really great study. We took a bunch of patients, made them all better with whatever therapy he used, and then stopped the therapy and followed them for the next year to see how the rate of relapse. And he found that 40% relapse within a year after stopping therapy. So this is kind of good news for patients because 60% didn't relapse in a year, so there's some durable effect to whatever treatment. Most of them probably relapsed in the second year. It does come back. But what was interesting, not only that they relapse, but the spots come right back where they were before. So it's not like when you relapse, you develop a new pattern. It comes back where it was before, telling me that there's immune memory. There's autoimmune memory being formed in that skin. So the fact that autoimmune memory was being formed was reminiscent of another memory T cell that was discovered recently in skin viral infections called resident memory T cells. So in that sense, the T cells go into the skin, they clear the virus, they leave some CD8 T cells behind. They're called resident memory because they never leave. They stay there forever. And that's good if the virus ever comes back, they're there immediately. We hypothesized that resident memory T cells were forming in vitiligo as well. That like a viral infection, you go in, you kill all the melanocytes, cause a spot, leave some CD8s behind to maintain those spots. And 3 other labs around the world also had that idea, and we all showed that that was true. And so here's just some of the data that we looked at. This is Jillian who did the work. This is human blood. We can use what's called a pentamer to find, by flow cytometry, to find melanocyte-specific T cells. And so you can see about 0.3% of all CD8s in the blood are melanocyte-specific in a vitiligo patient. In their lesional skin, that enriches about 10-fold, so about 4% are specific to any one melanocyte antigen. In the non-lesional skin here, we had none. But if you look at these pentamer-positive cells, so these are the autoreactive cells in lesional skin, if it's an active lesion, you can see about 40% of them are expressing these 2 markers, which mark them as resident memory T cells. But if you take a stable lesion, most of the cells are gone, but the ones that are there are almost 100% resident memory. That's CD69 and 103 positive. It essentially marks this cell population. So we were right. They were there. They were actually forming. And when we look in the mouse, we saw the exact same thing. We can take the mice down over time. We can see early on they're starting to form. And later at week 8 and 27, when the disease has stabilized, 100% of them are this resident memory T cell. So this suggests they're sitting there waiting, and if preventing repigmentation, or if they repigment with a conventional therapy that stuns them and turns them off, they're very much able to wake right back up and start the whole process again. So one thing that we learned from Thomas Gebhardt in Australia was that resident memory T cells rely on IL-15. So if you have an IL-15 knockout mouse and you give them a viral infection, resident memory T cells don't form. So this told us that either IL-15 is required for resident memory T cell formation or required for their maintenance and survival. And we were hoping it was the maintenance and survival because then you have a drug. So then we can target IL-15, turn that off, starve the cells of the cytokine, and see if they go away. And if they go away, we might actually have a durable treatment for vitiligo that doesn't come back. So we tested that, and IL-15 signaling is very complicated. Keratinocytes actually present the cytokine. They make the cytokine and they make this receptor called CD215 that holds the cytokine out and keeps it only in the epidermis, so it doesn't go anywhere. It kind of stays right in the epidermis. And the T cells make a heterodynamic dimeric receptor, CD122 and 132, and that's when they're in the epidermis, they can sense it being displayed by the keratinocytes and it signals. So we actually tested an antibody against this portion of the receptor for CD8 T cells to block it. So we let vitiligo form, and then we treated with IL-15 receptor antibody, and we saw excellent repigmentation, like I hadn't seen with the other drugs that we had tested. So mice that received vehicle got no improvement, 0% improvement, actually maybe got a little bit worse. And the mice that got IL-15 receptor beta antibody reversed. And here's an example. You can see a white tail becoming black. They got like 30% of their pigment back within just a few weeks. And most importantly, when we looked for the resident memory T cells in vehicle mice, this is what we saw. So we could see those cells, as we saw before, peppering the epidermis in the mice treated with vehicle that didn't get better. But the ones that got better and treated with IL-15 receptor antibody, you can see those T cells disappeared. And so I think what's happening when you block IL-15, not only do you make the mice better, but you can actually erase those autoimmune memory cells. So we thought this might actually be a durable treatment. So we tested that. We treated just for a very short time, and we found early on, before you even deplete the cells, you turn them off. So remember how important interferon gamma is for disease. If you block IL-15, you also, before the T cells get depleted, they actually make less interferon gamma. They start to turn off. So there's probably a double hit there. And when we treated the mice just for 2 weeks instead of 8 weeks, we saw that they actually repigmented for 2 months after that. So we treated just for a short time, stopped it, and they continued to repigment, suggesting that this is actually a durable response. Finally, we injected the spots right in the tail. So we just injected the tails of these mice with IL-15 antibody, and that alone was enough to repigment them as well. So I'm actually at the end, so the timing is just right. So we're dying to get this into humans. This is what my company that we formed is going to attempt to do. Actually, separately from that, Amgen has an IL-15, not a receptor, but an IL-15 cytokine antibody, and there's actually a clinical trial that's going to be tested, sponsored by the Immune Tolerance Network in humans, hopefully this year. And I'm going to skip ahead. So one of the ways that we study human skin is by inducing suction blisters in the skin. This is kind of, rather than a punch biopsy or a shave biopsy, we put a suction machine on their skin. In about 30 minutes, it forms a blister. We take that blister fluid out, and we can see all kinds of neat stuff. The T cells, the cytokines, we're using those as biomarkers in clinical trials. In collaboration with the Meet Pandia, we actually showed that after just 4 weeks of treatment, we can see biomarkers, T cells, cytokines go down and become undetectable in some cases. And this is way before you see a clinical response in vitiligo. So the companies are really excited about this because in 4 weeks, you can actually get an indication of whether the drug's working without having to do the 6-month trial. We're helping them with that. So this is a summary. CD8 T cell gets up, attacks the melanocyte, makes interferon gamma. The keratinocytes turn on and make CXCL10, and that recruits the CXCR3 positive CD8 T cells in a positive feedback loop to cause vitiligo. So we can shut this off, or the other thing is that the CD8 T cell becomes a resident memory T cell, lodges itself in the epidermis, kind of stays there forever, and that's dependent on IL-15, so we can target either the receptor or the cytokine with an antibody as a treatment. And then, as I mentioned before, we can shut off gamma signaling in keratinocytes with the JAK inhibitors. We can use antibodies against the cytokines. Those are all potential treatments. I promised the Dermatology Foundation I would put this slide up for the rest of my life because they supported me so much, 4 individual grants, and certainly the NIH as well, with an R01 and an R61. These are the people in the lab that did the work. It's a growing lab. We're hiring, so we're looking for postdocs and fellows and technicians. And it's a fun place to be there. Actually, we work really well together, and we're generating lots of new ideas. So if there's time, I can take questions. Scott.
You mentioned the extracutaneous manifestations of VKH and Alezzandrini's. Why is it that we don't see a lot more of those particular diseases when someone has immunologic attacks on their melanocytes?
Yeah, so fortunately we don't. So melanocytes live in the epidermis, they live in the hair follicle. They also live in the meninges of the brain, the inner ear, the retina, the uvea of the eye, and actually the heart. So we don't know what they're doing in those areas, but they're there. And when they get attacked, there are consequences of inflammation. There are symptoms. Fortunately, it doesn't happen more than it does. It's incredibly rare. And we think that the reason why it doesn't happen more often is because all those areas are immune privileged. So there are certain parts of the body that keep the immune cells out, because if they got in and started causing inflammation, they would cause problems like the eye and the inner ear and the brain. So there's something called immune privilege. We don't know exactly what it means or what it does, but it keeps the immune cells out. So I think that those with Vogt-Koyanagi-Harada or Alezzandrini actually have this combined problem of having vitiligo, and then also they either lack or they have poor immune privilege of all their sites. So then they get vitiligo, and then it does affect all those areas with the meningitis and the hearing loss and the vision changes. So we don't know. I'd love to know why those patients, they're incredibly rare, so they're hard to find and study. Adam?
What is the connection between, if there is any, alopecia areata and vitiligo?
Yeah.
We do see a lot of similarities in the immune kind of environment.
Yeah, there's an increased risk if you have one to get the other. Like many autoimmune diseases, the genetics overlap a little bit. But in alopecia areata, there's been this hypothesis hanging around for 20 years that melanocytes are the targets. Follicular melanocytes are the targets of alopecia areata. And that alopecia areata is also a melanocyte-mediated disease. I don't believe that. I think that if that were the case, we'd see much more overlap than we do. Or we'd see the hair turn white and then get vitiligo around it. And so I don't think that melanocytes are the targets, although in many cases, only pigmented hairs are targeted in alopecia areata. So there's this phenomenon of overnight graying. It's almost literal. Within a week, patients will go completely gray and say, and what happened there is they were salt and pepper, and then they got diffuse alopecia areata that only attacked the pigmented hairs, and they were left with just gray. And so there is something about pigment with alopecia, but I just don't know. I don't know what the connection is yet.
I just had a practical question. So we see a lot of Medicaid children, and Medicaid doesn't cover phototherapy. We need phototherapy. So not all the Medicaids, obviously it's, super this Medicaid versus that. So is there something that's happening on like the nationwide level from an advocacy standpoint, considering that it's an inflammatory disease, it has systemic manifestations, and we can make that case? Because for us, the biggest barrier is the pragmatic inability to treat, not necessarily we want to implement your regimen, but limited. Yeah.
So Medicaid covers phototherapy in Massachusetts, which is great. I'm shocked at how different insurance plans work in different states. So that's kind of a surprise to me that Medicaid doesn't cover it. It's pretty cheap and effective. But there is an advocacy effort. So we've actually gone and we've gotten Blue Cross in Massachusetts to cover home phototherapy units, to just buy patients units. Yeah. It's way cheaper for them, so it costs the insurance company about $4,000 to buy a patient a unit that'll last forever. It costs actually about $20,000 to get a patient treated in a dermatologist's office twice a week for a year. So we're trying to just do the math for them and let them know. We think that that's going to be coming, actually. A lot of them are, once they realize, they're saying, oh man, I can save a ton of money just by buying a booth. That would be a good solution. Your Medicaid patients probably can't pay out of pocket. A lot of times when patients, we calculate their copay for 2 years, and that's more than the cost of a booth. They just buy the booth at home and do that. It's tough here in the city I don't know if they have space for a booth. It's essentially the size of a doorway.
But the duration you're saying is a year, and then you have them maintain with a different pattern at that point? Yeah,
different sites of the body are different. So the face takes about 6 months. Hands will never repigment. The body, trunk, extremities can take about a year and a half. Maintenance, you can treat them for that long, get them better, stop it, and say, as soon as you see a spot, hit it with a topical. Or, once you accumulate enough spots, we'll just reinitiate phototherapy again.
Does your vitiligo team have a school psychologist or a counselor, or there's other issues associated?
When I was at Penn, actually, I started referring a lot of patients to psychiatrists and psychologists to have that aspect of their care. And one of the psychologists or psychiatrists said, you know, I don't know these patients. I'm happy to see them. You know, we can bring them in. I can talk to them. I don't know anything about vitiligo. I know about body dysmorphic disorder. I know, you know, that. But they said, honestly, you know, you're a doctor, and maybe you could do a better job counseling them, not as as a dermatologist than I can as a psychiatrist that doesn't know anything. And I kind of took that to heart. So I've done a lot of that myself. I've talked to them. If somebody came in and wanted monobenzone, I used to just refer them to a psychiatrist just to make sure, you know, that they have thought through the process. And now I do the counseling myself because I kind of feel like I probably can answer the questions better than anybody. We do at UMass have a mindfulness institute. It was actually started at the world. John Kabat-Zinn started this mindfulness movement all over the world, and he's faculty at UMass, started it there. So we actually have a really good support system there if patients want to do mindfulness, which is not technically meditation. It talks them through kind of the process of being familiar with their bodies, getting rid of anxiety, calming themselves, and we do refer patients for that.
Can you comment on cosmetic camouflage?
Yeah, sorry, I should put that in there. Dermablend and Cover FX are two good companies that make camouflage for vitiligo. And you really need those, so regular cosmetics don't work. You need that powder combined with a liquid base that holds it on. But it's really a lot of effort to put on, and it wipes off on things, collars and stuff. So it's still a real challenge. I don't have a lot of people that use it in the end. But if you have just a couple spots that you want to cover up, you can do that. But the other thing is, the face is easy to treat. So.
Just a quick question. We had a couple of patients that were presented with hypopigmented vitiligo, African American. Is that like just tricolor disease? Does that exist?
No. So tricolor almost always looks tricolor. You would think, well, if I catch it early on, I'm going to see, you know, two colors, hypo and normal. But you almost never do. Once you get a spot that's big enough, you always see those three colors because it doesn't take very long for that center to turn completely white. There are a number of hypopigmented disorders. One that was called hypopigmented vitiligo that Khalid Alezzandrini published, and I reamed him out for that. I was like, Khalid, you do a biopsy of that and there are melanocytes in there. I was like, that's not vitiligo. Call it something, whatever you want, but don't call it hypopigmented vitiligo.
Melanin and population melanocytes. We were trying to do maybe number analysis,
Yeah.
you know, volume. It was crazy.
Yeah. So he regrets having put that name out there, and he promised me the next time he publishes on it, he'll name it something else. But there's also progressive macular hypomelanosis. That's actually pretty common on the chest and back. I've got pictures of that for the residents when we do the differential diagnosis. We don't know what that is either, and there seems to be a fewer number of melanocytes in that as well. Some people think that it's a P. acnes infection.
It's like a backwards carve.
Yeah, it does. Yeah, it looks a little bit like that. Hard to know, but it responds beautifully to narrowband. So a lot of times I'll have a patient, if they have hypopigmented lesions here and here that look like that, I'll do a scraping KOH, and if, you know, just to rule out tinea. And if the KOH is negative, I'll usually have them treat with ketoconazole shampoo anyway for a couple weeks, just in case I missed it. And if they don't get any better, then I'll just give them UVB, and they respond really well. Mm-hmm.
Someone who has long-term vitiligo widespread, at what time do you decide there's no point of doing maintenance phototherapy? He didn't notice any new spots, but patients are so anxious about it, they want to keep on doing it once a week. They feel better, like it's doing something for them, but I don't see any spots.
Oh, once they're better, how long do you continue?
Yeah,
so I mean, so a lot of patients are worried about, a lot of docs are worried about narrowband UVB. You know, oh, when do I stop it? How long can I go? Do I need to, you know, a lot of docs will cut their patients off after a year. You can't have it more than a year. Giovanni Leone is actually a phototherapy expert from Rome. One time I was giving a lecture at the AAD and he was in the audience, so I kind of asked him, I said, Giovanni, when do you stop phototherapy? He said, after a year and a half. And I said, why? And he's like, I don't know. I don't have a good reason. And now, so we actually have a good data over about 30 years that UVB does not increase the risk of skin cancer, very much unlike PUVA. We know that vitiligo patients have a 3-fold lower risk at baseline of skin cancer. And so I actually don't worry about giving UVB at all. Like, I give it for as long as I need to. If my patients say, oh, I just like it, I feel better, I'm afraid, I keep them on it. You know, why not? The other piece actually is, it's not published yet, but there was an abstract given by a group in Korea where they actually did a huge population-based study of patients on narrowband UVB to see what other They know, you know, they confirmed that it doesn't cause skin cancer, but they were like, well, what else might it be doing? And so they looked at a lot of other parameters. The only thing that fell out was that it actually appeared to be cardioprotective. So patients on narrowband UVB for greater than 2 years lifetime had fewer cardiac events, fewer heart attacks, fewer strokes. So if anything, it's like healthy. You know, if you think about it, we evolved for hundreds of thousands of years in the presence of sunlight, and the sunlight gives us vitamin D. That we demonize sunlight, and I don't know that. I'm kind of rethinking that a little bit.
Do you have any data would, I'm sorry,
No, go ahead.
do you have any data would long-term narrowband UVB be kind of immunosuppressive of vitiligo to recur again?
Yeah, we don't know that. Somebody's got to do that study where, you know, how long do you give it, how frequently, and then stop, and then the relapse rate is lower than 40%. I mean, that we don't know.
So there's actually more to the story about the cardioprotective effects. So Richard Weller out of England has shown that UVB will produce nitric oxide through a non-nitric oxide synthase pathway that was shown to actually just small amounts will actually reduce blood pressure.
Really?
So he's a big advocate, even as a dermatologist, that you should go outside and get limitless sun exposure, which we know is not necessarily a good thing. It's about finding the kind of sweet spot where you still get those cardioprotective effects, where narrowband, that kind of is the case. You're getting very small amounts, very controlled, energy levels, right?
Damaging UVA.
So I believe we understand why that would happen. So that's actually those two parallel studies should probably be married.
That's cool. Yeah.
Regarding the dexamethasone, because I do use that based on like the literature that you talked about, but in the kids I've been doing 2 milligrams Saturdays, Sundays, is that, and then for 3
Exactly what I
months,
do
that's how
too.
you do it.
Yep.
And then
2 in kids, 4 in adults.
Okay. So do big kids count as adults, like
Yeah.
teenagers? Okay.
Yeah, I'll give them 4. Thanks, guys.